Today we are going to discuss the advantage and disadvantages of minimal access surgery. In this we will discuss some of the important points regarding the most important advantage, disadvantages, contraindication and some of the specific indications of the minimal access surgery. What is the most important advantage of minimal access surgery? If anybody will ask you, or if in exam it comes that what is the most important advantage, then it comes the improved diagnosis. One of the most important advantage of minimal access surgery over open surgery is improved diagnosis. Diagnosis was never that much clear in open surgery, although it is generally patients are misguided. Sometimes once the patient were going to the open surgeon, they were convincing the patient that if we will open the abdomen, we can see all your organ, we can do the surgery more complete. If they will do laparoscopy, they will leave a lot of pathology inside, they cannot see everything. Patient will say that no, the laparoscopic surgeon was saying that he can see more. Then the surgeon will say that you have a house, patient will say that I have got one. So, how do you enter in your house? Through your window or through your door? Patient will say I always go inside my house through my door, I never use window. So, that is what I am saying. If we will do laparotomy, we will make a door and we will enter into the abdomen, we can palpate all the organ, we can see all the quadrant. The laparoscopic surgeons, they are doing with the buttonhole, with the window, and they are never complete. Your pathology will be left inside, but actually it is wrong. Due to the magnification and due to the long cylindrical instrument which can enter into all the recesses of the body, even the diaphragmatic recess, paracolic gutter, splenic fossa, anterior cul-de-sac, posterior cul-de-sac, you can examine each and every organ into the abdomen. Just like this patient was suffering from lower abdominal pain. The initial diagnosis was looking like it is acute appendicitis. Ultrasound was showing some fluid collection, little fluid, it was only 200 ml fluid. Next day pain increased, laparoscopy was performed and it was found that there was laceration into the liver and diaphragm, and the huge amount of the blood was found, approximately 1 liter of blood within 24 hours of the gap of the diagnosis and surgery. That blood has increased, anterior cul-de-sac is filled with the blood. Pregnancy test was negative, it is not a rupture ectopic. Anterior cul-de-sac was sucked out, posterior cul-de-sac also suction of hemoperitoneum was done, tubes were found fine, ovary was good, paracolic gutter were correct, and ultimately once the history was taken strictly, then it was found that it was a domestic violence and there was fight in between the husband and wife, and she fall on the corner of one table and she got a blow into the liver. Because of some reason she did not tell about that, and actually the cause of bleeding inside the abdomen was a small tear into the liver, but it was already settled, there is no active bleeding. Thorough lavage was performed and telescope was withdrawn outside. For the same reason, if someone will do laparotomy, you can understand that even this laceration which was near the diaphragm cannot be seen in laparotomy, like it was at this point here, which is not possible to see by any other means. This was a real laceration. Again second case, this is a very interesting groin swelling. This patient ultrasound was showing that it is just like a sauce abscess, and there was no any other sign and symptom, everything was looking normal, but only one thing, that patient peristalsis was stopped. It was a paralytic ileus feature. So, it was thought that it may be subacute obstruction or it may be some peritonitis. Once the telescope was introduced inside the abdomen for diagnostic, it was found that it is a case of amaranth hernia. We know that in amaranth hernia, appendix has the herniated into the deep ring. This is the appendix, this is cecum, this is tinea coli, and it is herniated into the deep ring. So, one small incision was given onto the peritoneum and then the appendix was withdrawn. Appendix was gangrenous because of incarceration into the deep ring, and this was incarcerated appendix, gangrenous appendix. So, knot was not used, endo-GI linear stapler was used and appendicectomy was performed. Then huge amount of the pus came out through the sac, suction irrigation was done, because in this infected state you cannot use the mesh. So, only suture was applied, thorough suction irrigation was performed locally, not generalized, and then one drain was introduced percutaneous through this deep ring. This is a drain coming, and the patient was discharged after 1 day. Suppose you will believe the ultrasound alone, and if you would have done the incision and drainage, then there was a sure that fistulization will form and fecal fistula will develop. So, most important advantage of laparoscopy is improved diagnosis. Second most important advantage is less tissue dissection and disruption. Tissue dissection and disruption is 6 times less compared to open surgery, and tissue dissection and disruption is of 2 types. One is abdominal wound, another is target wound. Abdominal wound is a small, that is why the name is minimal access surgery. So, there is no question about that, but target wound infection, target wound disruption is also less in laparoscopy. Reason being that in open surgery you have to use a lot of retractors, like if you are performing the hysterectomy, you are using bladder retractor, you are using bowel retractor. These all retractors are creating a invisible single layered serosal injury. And when you are handling the uterus, holding the ovary, touching the tube, these all are creating little bit serosal injury, which is invisible, we do not see it. And later these are the responsible for the infection or adhesion. But in laparoscopy, because of magnification and because of the small diameter instrument, directly we can reach over the target of dissection. We do not unnecessarily do collateral damage, unnecessarily we are not doing collateral damage. So, that tissue disruption is 6 times less compared to open. Next advantage of laparoscopy is less wound infection. Less wound infection. Wound infection is of 2 types. One is target wound infection and another is port wound infection. Target wound infection means, suppose you are doing appendicectomy, then infection in the cystic stump in the right iliac fossa, that is called as target wound, and abdominal wound is port wound. Target wound infection is rare in laparoscopy. It is absolutely rare. Yesterday we were discussing about the sterilization process of laparoscopic instrument. We were discussing different sterilization methods like ethylene oxide, ozone chamber, gamma ray chambers, biguanides, para-ophthaldehyde solution and the glutaldehyde. Most commonly used is the glutaldehyde, that is Sidex. And we came to know that in overloaded hospital, in BG hospital, where they have only one set of instrument and they have to perform 4, 5, 6 surgery in the same day, they do not give proper contact time for the instrument. And there is a lot of abuse of the sterilization in laparoscopy. We do not do proper sterilization, but in spite of that, infection is rare in the target wound. Now, the question is then why it is so? There are 5 factors responsible for less infection in laparoscopy. First factor responsible is interior milieu. Interior milieu is a Latin term which is coined for laparoscopy environment. Interior milieu means maintaining the environment of inside and cutting it off from outside. In laparoscopy, interior milieu is maintained, because once we put the trocar and once we put the CO2 gas into the abdomen, abdomen is getting inflated and it never allows the external environment bacteria to enter into the abdominal cavity. If there is any breach into the continuity, then the CO2 start escaping out, but it will never allow any external operation theatre environment to enter into the abdominal cavity. This is the meaning of interior milieu, and due to interior milieu, infection is very less. In open surgery, interior milieu is not maintained. If you have not wear the mask properly, if you do not have a proper cap, if some nurse is harboring some Staphylococcus aureus in the nose and she is sneezing or coughing, or too many people are in the operation theatre, if operation theatre does not have laminar flow, if operation theatre is not properly fumigated, there is always a possibility that external environment bacteria will enter into the abdominal cavity and it will infect the target organ. But in laparoscopy, even if you want, you cannot do that, because external environment is cut off from the outside and there is no chance of entry of those bacteria into the abdomen because of interior milieu. Second factor is carbon dioxide. Carbon dioxide has a great property that as soon as it comes into the contact with the peritoneal fluid, it turns carbonic acid, that is HCO3, and then it turns the pH of the peritoneal fluid to 5, it becomes acidic and it turns into a weak antiseptic solution. So, entire peritoneal fluid is now a antiseptic solution, and suppose due to any reason any bacteria enters also, as soon as it will sit over any of the fluid, it will get killed by those carbonic acid, and then further propagation and reproduction and the bacterial growth will stop and it will help us to fight against the infection. Third factor which help in laparoscopy for less infection is less tissue dissection and disruption itself. We all know that for any infection to develop, there should be dead tissue, necrosed tissue, because necrosed tissue act as a culture medium for bacteria to grow. And if there is less tissue disruption, then chances of infection is also less, because dead tissue is not there, pus cell is not there, disrupted cellulolymphatic tissue is not there, then bacteria does not have any food to survive, and that is why infection is less. So, first is interior milieu, second is carbon dioxide, third is less tissue dissection and disruption, fourth is less secretion of C reactive protein and interleukin 6. There are two chemical mediators which is secreted by our body in response to any trauma. If we will fall, if we get burned, if we will get fracture, if we will get road traffic accident, or simple if you have any influenza or fever, our body is secreting C reactive protein or interleukin 6. These two chemical mediators are considered as a autogenous steroid, and they are beautiful chemical mediators which gives our body capacity to tolerate stress and strain, so that we can tolerate the trauma or stress. But the problem with these two chemical mediators is that these are immunosuppressant. It decreases the immunity of the body, just like steroid. If your patient is terminally ill in our ICU, we are giving high dose of steroid, but whenever we give high dose of steroid, we always have a apprehension then what will happen for the infection. So, exactly same way C reactive protein and interleukin 6 act as an immunosuppressive agent. In open surgery, amount of secretion of the C reactive protein and interleukin 6 is 1000 times more than the open surgery laparoscopy. And due to that, in open surgery immunosuppression is much more than laparoscopy. In laparoscopy, C-reactive protein and interleukin 6 is secreted very minimum in the quantity compared to open. And that is why immunosuppression is less in laparoscopy compared to open. And because of less immunosuppression, chances of infection is less. This is the fourth factor. And the fifth factor responsible is that metamorphosis and transmigration of the peritoneum and the disrupted serosa is much more faster in laparoscopy compared to open. What does it mean? That if we do laparotomy, then there is a one big incision. So, the peritonization takes time, and we all know that peritoneum is closed by the metamorphosis and transmigration, means peritoneum has a capacity to regenerate and it will cover the abdominal wall from inside. In laparoscopy, this metamorphosis and transmigration and repair of serosa as well as peritoneum is complete within 100 hours, whereas in open surgery it takes 300 to 500 hours, many times more. Until the entire tissue is regenerated, there is a chance of infection. So, in laparoscopy, because of multiple wound, surface wise area is bigger than one big wound. Multiple small wound is surface wise area is bigger than one big wound, and because surface area of the multiple wound is big, so that peritoneum regeneration is fast. Just like when you are doing skin grafting, you are not using a big one single patch of skin, you are keeping a small patches, multiple patches, because multiple patches has more surface area. So, propagation will be faster. Just like in the garden, if you want to put a grass and if you want to propagate the grass faster, you have to spread the grass in many places. If you will put all the grass at one place in your garden, it will take a lot of time for grass to develop, but if you will spread it in multiple small patches, it will propagate much faster. So, exactly same way, injury of peritoneum and serosa and the other layers in laparoscopy is at multiple places, and that is why healing is fast. Suppose I have been kidnapped by one terrorist and he will tell that I will cut your body 10 centimeter. You want 1 10 centimeter or 10 1 centimeter. I will request him to cut 10 1 centimeter. If you will cut 10 1 centimeter, 1 centimeter here, 1 centimeter here, 1 centimeter here, it will heal within 1 week, and he will cut 1 10 centimeter, and if it will not be stitched, it will get infected and it will not heal. Same thing works in open and laparoscopy. One big wound infection is very bad, a small wound infection multiple is good, and it has less chances of infection. Not only that, in the multiple wound, because of surface area of multiple wound is big, so more number of neutrophil and macrophages are working on the margins, so that they have more chances to fight against the infection. But one big incision, surface area wise is small, and in that less number of neutrophil and macrophage is present, and then they have more chances of infection. So, multiple wound always has a less chance of infection. So, these are the factors. Again to summarize, interior milieu, CO2, energy sources, this I forgot. In laparoscopy, dissection depends upon the energy sources. We always want to achieve the hemostasis before dissection. We do not want that once bleeding will start, then I will use current, because we do not want to achieve hemostasis later, we want before, that is called as preventive hemostasis. Preventive hemostasis. So, always we like to use energy. Minimum temperature generated is by harmonic, that is 80 degree centigrade, and maximum sometime in the bipolar goes up to 350 degree centigrade. So, at that temperature, even if the tissue is infected, it gets disinfected. So, that also help us to fight against the infection. Then less tissue dissection and necrosis, multiple incision better than one, more number of macrophage and neutrophil on the work, and less secretion of C reactive protein and interleukin 6. So, these are the factors. Infection is very less in laparoscopy compared to open, but one thing is kept in the mind, that there are 3 B which we should not forget. One B is bleeding, second B is bile or bladder, and third B is bowel. In laparoscopy, if infection happens, then it is disaster. Reason being that it is a completely closed, and if infection happens, it develops abscess or peritonitis. In open surgery, if infection happens, there is a way for this infection to discharge. Sometimes some stitch abscess happens and we are discharging it, we do a lot of dressing, it will heal, but in laparoscopy it is disaster. So, we should be very serious about the 3 B. Suppose you did surgery today and within first 24 hours your patient is deteriorating, patient is pulse is tachycardia, volume of the BP is low, patient is looking sick, patient is restless, patient has increasing pain, then you should think about bleeding somewhere. If you have done TLH, that may be some bleeding from uterine or the vaginal angles or the vault. If you have done the cholecystectomy, may be some bleeding from liver bed, cystic artery, anywhere. Second B is bile or bladder. If first 24 hour patient was okay, then from 24 to 48 hour patient is deteriorating. Suppose you have done cholecystectomy and the second day of the surgery patient is looking sick, increasing pain, not waking up, trying to lying dormant on the bed. That means you should think about some CVD injury. If you have done the CVD injury, first 24 hours nothing happens to the patient, patient looks normal, because it takes time for the bilirubin to increase, it takes time for the biliary peritonitis to develop, it does not develop immediately. And if you have done the ureteric injury, within first 24 hours it will be confusing, you will not know, patient is under influence of anesthesia as well as analgesics. So, it will be confusing. Most of the ureteric injury reflect within 24 to 48 hour post operative period. So, this is second B, that is bladder injury or ureteric injury, and third B is bowel. If the first 2 days patient was okay and the third day suppose patient was discharged and third day of the surgery patient is coming back in the emergency department, getting admitted again, increasing abdominal pain, fever, tachycardia, that means it is third B, and most common probability is bowel, and it could be the bowel injury, because bowel injury once it happens in the laparoscopic instrument, it is a small, it is not a big injury. So, it takes time for peritonitis to develop, and most of the bowel peritonitis due to the rupture of the bowel reflect the third day after the laparoscopy. So, it is not necessary that this is the only cause, but probability is high for these regions, and we should keep in mind thinking like suppose first 24 hours was uneventful and third day patient is coming back, that is very less likely it is a problem of bleeding, very less likely. And if it is first day patient has an increasing tachycardia and pain and other problems, then it is very less likely that it is due to the bowel perforation, because bowel once perforate immediately peritonitis does not happen, it leaks little fecal matter, then it get infected, then it irritates, then it propagates, and then it takes time. So, this we should be very careful in laparoscopy. Infection does not happen, but if it happens it is due to some of the complication. One another problem is port wound infection. Port wound, target wound infection, internal wound infection is rare in laparoscopy, but port wound infection is not rare, especially if your trocars and cannulas are not properly sterilized, then the spore producing organism infection is always you should consider an atypical microbacteria, pseudomonas infection, and these always we should consider. Now, the next advantage of laparoscopy is less adhesion. It is very interesting to know that 80% of the laparotomy result into adhesion. 80% of the laparotomy patient they develop adhesion, but good thing is that 90% of these adhesions are asymptomatic. They do not have any symptom, because if a small adhesion of the omentum does not matter at all, it is there, patient never knows. If a small uterus, a small portion, bladder, a small portion is adhered after caesarean section, it does not have any symptoms. In laparoscopy, adhesions are rare. Why adhesions are rare? Because port wound is always away from target wound. We know for any adhesion to develop, two tissue which want to adhere together, both of them should be injured. If you will cut both my finger and plaster together and leave for 7-8 days, it will join. But if you will cut one of my finger and other is not injured, is healthy, and then you plaster, the adhesion will never develop. In laparoscopy, always target wound is away from port wound. If you are doing appendicectomy, your one port in umbilicus, other port in left iliac fossa, and third port is right subcostal or suprapubic, and peritoneum just above the appendix is completely healthy, and healthy peritoneum is the best known adhesive barrier. So, once the appendix is removed and this stump of the appendix or inflamed cecum or the base, if it comes into the touch of the peritoneum just above, it does not get adhered, because peritoneum just above is healthy, and this stump of the appendix will never come to the left iliac fossa, and it will never go to the right hypochondrium to adhere. But in open surgery, we are bound to give incision where we want to operate. In open surgery, if you are doing appendicectomy, you cannot give incision to the left iliac fossa. You have to give the incision over the McBurney point. And after removal of the appendix, the base of the appendix, the inflamed cecum and the inflamed peritoneum and the abdominal wall comes into the contact for few hours, fibroblasts and collagen will develop, a scar tissue will start growing, that will mature and it will adhere. If you are doing caesarean section, the bladder, the cut wound of uterus come into the contact with the abdominal wall, it adheres. But in laparoscopy, because target wound is away from port wound, chances of adhesion is very less. Another is single layer peritonization is within 100 hours. So, once the peritonization is complete, chances of adhesion is no more. Another is early mobilization. In open surgery, due to the pain, patient cannot be mobilized early, patient is bedridden, and sometimes we give narcotic analgesics, because we do not want patient to suffer, and those all narcotic analgesics has a drawback that it create the sluggish bowel movement, and then patient is sleeping, lying dormant, and whenever two layers of the injured bowel or the solid organ come into the contact and patient is sleeping for 6 to 8 hours, then the fibroblast collagen grows and adhesion develops. But in laparoscopy, our patient is early mobilized, patient can go to the toilet to wear the urine himself, patient can take the side, patient can sit, and that is why chances of adhesion is less. Then paralytic ileus is also less, and another important thing, humidity is maintained. Due to the interior milieu, inside environment is completely cut off from outside and humidity is maintained. And because of the humidity is lost in open surgery, sometimes dryness of the intestine is one of the reason of the paralytic ileus. When you do open surgery and sometimes you have to put the bowel above the abdomen, what you are doing? Covering with the sponge, putting a lot of saline, because you never want to get it dry. If it is dry, dry serosa means dead serosa. If serosa of the bowel you make dry, that means it is dead, partially single layer, and then it takes time to recover. There will be paralytic ileus. In laparoscopy, it is not possible. So, adhesion is rare, but there is one exception. Sometime in laparoscopy, adhesion occur and it is extensive. Why? Because of our mistake. We do two technical mistakes, that is why adhesion develop more. First mistake is that at the end of surgery, without evacuating the gas completely, abruptly you are pulling the cannula, and suppose gas is still inside the abdomen and you are abruptly pulling the cannula, then the bowel or omentum, due to the sudden gush of the gas, bowel or omentum will get plugged into the wound, and once it is plugged into the wound, it get adhered. And sometime at the time of closing of the rectus, accidentally we suture that also with the rectus, because it was plugged and we do not know, we think that this is fat or something, and then we suture, and that can create a very bad obstruction, fistulization, adhesion. So, what is important, that at the end of the surgery, when you have to deflate the abdomen, open the valve of all the cannula, and all the cannula should be removed under vision, and the last cannula when you are removing, you should push the telescope in and then you should try to pull the telescope cannula over the telescope. Cannula should be pushed over the telescope means cannula should not be directly pulled, otherwise it is like a cylinder and this cylinder can suck the momentum. So, always push the telescope in and then cannula should be slided over the telescope. So, that telescope will keep the bowel and omentum away. This way you will not invite the adhesion. Second technical factor is a lot of leak. A lot of leak means all your cannulas are old, all the valves are defective, washers are broken, because you are using reusables, you do not have money to buy disposable, and it is 10-year-old instrument which has never been replaced. A lot of leak is there and if more than 6 liter of the gas will leak for more than 10 minutes, 5 to 10 minutes, then there is a possibility of the patient to develop hypothermia and dryness of the intestine. This hypothermia sometime may be dangerous in extreme winter season. Suppose there is extreme winter season and you are going for a shower in a bathroom for having bath, and you get a shower, your body is wet, you come in the bedroom and someone will just switch on the fan, you will start getting shivering and you will immediately tell that stop the fan, I am getting cold. Why you are getting cold? Because your body is wet, and in the wet body if there is evaporation, wherever there is evaporation there is cold, and that is why you are getting shivering. Exactly same way extreme winter season is there, you are doing laparoscopy, the cold CO2 is coming from cylinder coming into the abdomen and because of all the defective cannulas, it is leaking out. So, it is making a flow of air CO2 through the abdominal cavity and going out. That will create a lot of evaporation of the splanchnic fluid, and then evaporation of the splanchnic bed will create the splanchnic blood to become cold. This cold blood will go to the portal vein, from portal vein to the vena cava, from vena cava to the heart, and there will be ventricular fibrillation. And this ventricular fibrillation rarely can create the death of the patient on the table. Yes?
Sir, insufflators are mostly with the temperature regulator.
Yes, that I am coming.
What happened with that?
Yes. So, that I am coming. So, this is a big problem, and he is absolutely correct. To prevent this problem, nowadays insufflators are coming with the CO2 warmer. What is CO2 warmer? In not all insufflators. In the cheaper insufflator, unfortunately, it is not there, but in the good insufflators, they are equipped with the CO2 warmer. So, CO2 warmer has a function that it will prevent hypothermia. Just like if you come from the bathroom and if you will switch on the blower, or you will try to dry your hair with the hair dryer, you will not get cold, you will not get shivering. It will be very smooth, you will feel it good with the hair dryer, because it is warm hair, and warm air will give you the much rapid dryness, and that is the problem here, that use of CO2 warmer can prevent the hypothermia, but theoretically it can increase the dryness of the intestine much earlier than without warmer. Just like with the hair dryer, you can dry your hair much faster than the normal fan, because warm air, if it is leaking, it will create the serosa of the bowel completely become dry. Suppose you are doing hysterectomy and you are busy during hysterectomy for 3 hours, and there was a lot of leak from many cannulas, and your insufflator is equipped with the CO2 warmer. Now, all the fluid of the bowel serosa of the upper abdomen is completely dry, because wherever there is a leak, humidity will not be maintained, because wherever there is evaporation, there is dryness, and then once the serosa is dry, it is dead, and post operatively your patient will get a very bad paralytic ileus, and there will be possibility of interbowel loop adhesion. That is why whenever surgery is prolonged for long time, then time to time you should try to sprinkle some normal saline over the small bowel to keep it moist, and if you can afford, you should buy the CO2 warmer. There are possibilities that you can buy the expensive insufflator. Nowadays, insufflators are available which has the CO2 warmer with humidifier also. So, those CO2 warmer with the humidifier, if you will use it, it can prevent the problem of the hypothermia as well as humidity loss, and then chances of adhesion will be less. So, I will show you later. So, this is possibility, but do you know what is the cost of the insufflator which is inbuilt CO2 warmer with humidifier is approximately 12 lakh rupees, and this 12 lakh rupees you do not have to spend if you will just take little care that you do not leak. If you will not leak, this will not happen, humidity will be maintained, but if you are leaking, humidity also will be lost and the temperature also will be lost, and your patient can get hypothermia as well as dryness of intestine. Now, next advantage is 3 times earlier return to work. Generally, laparoscopy you can advise the patient to return to the active sports, exercise, cycling, jogging 3 times earlier. Suppose you have done the open myomectomy, then you tell your patient that you can join the active sports after 6 weeks. In laparoscopy, on an average, after 2 weeks only patient can return back to the normal activity, on an average. Next advantage is regarding the pain. In laparoscopy, the pain is 6 times earlier less than the open. In University of Tübingen, they have done one study. 600 patients were operated by open surgery, 600 operated by the laparoscopy, and they calculated the amount of analgesics used post-operatively within first 72 hours in both the group of the patient. And it was found that consumption of analgesic in the laparoscopic group was 1/6 less compared to open, and that way it is a indirect study which says that laparoscopy has less pain. But in that study there was a peculiar outcome, that expectation from the laparoscopy was much higher than the open, because once the patient read the internet, they do the googling, they see the literature, they think that laparoscopy means a surgical rose who is going to, my surgeon is going to offer me. So, if you will go for a round, suppose in the morning you have done laparoscopy and at evening or at afternoon you will go for a round, and purposefully if you will ask the patient that do you have any pain, none of those patients will say that I do not have any pain. They will say that yes, it is painful, you know, I have little pain here and here also. You will ask that can I give some injection for this pain? They will say no, injection is not required, I am fine, I can tolerate. But in open group, if you will go to see the patient, patient is already crying, you do not have to ask anything, patient is already crying, you will tell the nurse to give some injection. So, that is why expectation is high in laparoscopy, because the same patient has never experienced the pain of open surgery, is not it? So, they do not know how much less they are getting, but even the less also for them it is more. Now, next advantage is less aspiration pneumonia. We know that for any general anesthesia there is a possibility that we can get the aspiration pneumonia, because general anesthesia has a problem that it will paralyze the cilia of the nasal cavity and airway. All the airway cilia is paralyzed, and if all these cilia are paralyzed, there is a congestion and there is a pulmonary retention of the mucus. Mucus plug will get trapped and alveoli will get completely congested. This happens in every general anesthesia. In laparoscopy also it happens, but after laparoscopy patient can cough, and cough is the prevention of this type of aspiration pneumonia, because once the patient will cough, all the plugged mucosa into the alveolar sac will be expelled out, and then patient will not have a fear of developing the pneumonia. But in open surgery patient cannot cough due to pain. If you have done laparotomy, big incision, and post operatively cough means it is very painful, but and then patient will try to suppress the cough, and you are also giving narcotic analgesics. All the narcotic analgesics are cough suppressant also, and then patient develops pneumonia. But in laparoscopy patient can change the posture, patient can expectorate all the retention of the mucus, patient can go to the washroom, patient can walk, so chances of aspiration pneumonia is less. This I am talking about complete perioperative, but one thing is important, laparoscopic risk of intraoperative aspiration is much more than open, especially for gynecologist, because your patient is a steep Trendelenburg, and due to that there is a pulmonary hypertension which develops, because blood get congested into the lung, and due to the positive pressure of the stomach there is always a chance of the reflux, and if your anesthetist has not plugged the endotracheal tube nicely, then there is a chance of aspiration pneumonia also. So, that is why when you are doing a steep Trendelenburg position, your anesthetist is not happy with you. He is always objecting that it is enough, do not do much down now, because they know that it will be not good for their patient. And especially post operatively, due to those congestion, you should keep the patient prop up, and you should try to patient to recover much earlier, because your patient 3 hour, 4 hour head down is a bad posture for the lung. This is a small problem for the gynecologist. For surgeons who is doing upper abdominal surgery, this problem is not there, because their head is up. So, intraoperative risk of developing pneumonia is more in laparoscopy, but if you will calculate the overall incidence, then the laparoscopy has much less pneumonia cases compared to open surgery. Now, next advantage of laparoscopy is DVT. DVT of that is a deep vein thrombosis. Open surgery, there is a great risk of the DVT for the high risk patient, in which the thrombosis of the deep vein of the calf can develop, and then it will be dislodged from here. Once it is dislodged from here, it may be captured by the saphenous filtering system, and it may be destroyed by the patient's own defense mechanism. But if it could not be destroyed, then the next destination is the right heart, and from right heart it will go to the lung, and once it will go to the lung, it will create the pulmonary infarction, pulmonary embolism and infarction. That is why post operatively, if you have done a big laparotomy, patient is in the ICU, then you have to create a pneumatic pump into the calf, or if you do not have that facility, then at least the nurse has to massage the calf muscle, patient has to encourage to do the calf exercises, patient has to be very aware of this complication, and the nurse should do the proper nursing care. In laparoscopy, even if you do not tell, patient will bend the foot, patient will walk, patient will try to take the posture changes, and chances of DVT is rare. But again one exception is there, that intraoperative risk of developing DVT in general surgical procedure is much more, intraoperative risk. For gynae, DVT risk is less, because your patient is head down and the patient leg is Trendelenburg. So, due to that you are already supporting the calf muscle, and due to the posture there will be no stagnation of the blood in the deep vein of the calf, because venous drainage will not be obstructed. The gynecologist has another problem. If you are doing TLH or myomectomy for 3-4 hours, there is chance to develop the compartment syndrome. Because of the pressure and ischemia of the compartment of the leg, there will be another problem. But the DVT chances is much high in the obese patient, morbid obese patient, or patient who is a smoker, or patient who is taking oral contraceptive. But in general surgery, most of the time your patient is head up, and you are not putting the patient in the lithotomy, and especially in the bariatric surgery, due to the positive pressure of the gas, there is a decrease in the venous return, and there is an increased risk of the DVT intraoperatively. That is why in those high risk patients, we should give low molecular weight heparin as a prophylactic against the developing the DVT, and a spiral stocking or pneumatic stocking should be applied over the calf muscle to decrease the venous retention, the blood retention and the thrombosis. So, this is little risk intraoperatively, but overall risk of the DVT is very less compared to open surgery, very less compared to open surgery. So, this is one of the advantage, that is 1/8 time less incidence. Another advantage is less immunosuppression. This already I have discussed, that C reactive protein and interleukin 6 is there. This macrophage has a mannose binding protein. This mannose binding protein has a lot of memory, and this memory comes from our ancestor also. any infection which we have got, it is possible that our son will also not have the chances of getting that infection again. Genetically also it is passed. So, it has a lot of memory, and what is the memory? That it can recognize the bacteria, but C reactive protein has a problem, it will block the manose binding protein of the macrophage, and after that these macrophages are useless and they cannot recognize any bacteria, and bacteria has a good time to propagate and to do whatever they want, because immunity is lost. And once the immunity is lost, there is chance of infection. So, in laparoscopy there is 1000 times less immunosuppression compared to open surgery. Open surgery immunosuppression is much more. Next advantage is cosmetically better. Once the laparoscopy was started, at that time the first and the only advantage anybody was seeing in laparoscopy was cosmetic advantage, but today we are keeping it at last, because laparoscopy has all these advantages which we have discussed before. These seems to be much more important than cosmetic. In all the time, big incision means big surgery. Laparoscopy, we also say laparoscopy as band-aid surgery, because the same surgery can be performed by the help of a small band-aid. Here we can see this is a cholecystectomy, starting from the Ziffy sternum to the anterior superior iliac spine, that much big incision is given, and that much big incision just for cholecystectomy. This is a incision for duodenal perforation, and here it is a drain, 2 drains also. Same type of surgery, this is for myomectomy. Here also this is for myomectomy, hardly after 6 months you cannot see any port. This is for cholecystectomy, one is here, one is here and one is here, and it is after 6 months, that also will not be visible. This is again cholecystectomy, one port is here, another is also not visible. Sometime if it is visible, patient can wear some skin piercing ornament and they can hide. So, this is also one of the big advantage, that is cosmetic outcome. Now, we will discuss few of the disadvantages of the minimal access surgery. One of the disadvantages is that it is more expensive. Laparoscopy has one of the big problem, that it is endless to buy the instrument. You keep on buying the instrument and still it is not complete. Your initial investment is approximately 25 lakh rupees for if you want a good HD system with the good HD camera, with the good LED light source, with the good HD monitor and initial equipments. 25 lakh rupees is the minimum starting cost. After that you have earned for 6 months, 1 year, then again they will come with the harmonic, they will take again your 15 lakh rupees out. Then again you earn, they will come with the ligation, they will take with the force triad again 15 lakh rupees out. Then again you will come, they will come with the Versa point, they will come with the Versa scope, they will come with the thermal choice, they will come with the different type of bipolar hysteroscopic generator, and there is no end of buying the instrument. Ultimately for 10-20 years you will earn, they will come with the Da Vinci robot and they will take your $1 million out. That will be a huge loan over you, which you have to whole life you have to give the EMI for those loans. So, this is a big conspiracy against the common man, because surgery is now in not the hand of the surgeon. From the hand of the surgeon it is slipped now into the hand of industrialist. Whatever we are earning in the laparoscopy, approximately 50% of that money is directly going to the United States of America. It does not remain in the India, it goes outside. Reason being, a lot of instruments are patented, like harmonic is from Ethicon patented, harmonic probes are patented, ligation probes are patented. This is from Covidian, which is a company American. So, whatever we are earning, we are sending to USA. This is a conspiracy, and because industry is ruling out due to the copyright due to the cost of one harmonic probe is approximately 35,000 rupees, and ideally it is single use. If we are using 5 times, 10 times, then it is ethically wrong, is not it? It is not a sterilizable instrument, it is a single use instrument, it is written there. So, every surgery 35,000 is going to USA. So, this is conspiracy. What is this? This is useless. So, another problem is operative time. The patient who cannot tolerate the anesthesia for long time, they are not a good candidate to do laparoscopy, because it is inherently slow in nature. You cannot be fast, because you are not working in 3D, you are working in 2D, and laparoscopy is not a surgery in reality, it is a surgery over image, it is a virtual surgery, and whenever you do virtual surgery you cannot expect the same speed. So, it has to be slow in nature. So, the patient who is road traffic accident or severely injured, or they cannot tolerate the anesthesia due to COPD, cardiac disease, they are not a good candidate for laparoscopy, or patient who is in shock.
All patients or what was the ASA classification?
Yes, ASA classification 3 or 4. ASA classification 3 or 4. If ASA classification 1 or 2 is okay for laparoscopy. 1 means normal ASA. ASA is called American Society of Anesthesiologists. ASA 1 means normal healthy patient. ASA 2 means mild systematic disease, which is controlled.
It was skillful hand and vacuum.
Yes. So, I will come. Do you know why he is objecting me? I will tell you that laparoscopy can be performed even in the ICU, when it can be performed, but not for every patient. Laparoscopy can also be performed the patient who has a trauma patient. It can be, but not all, because the patient who cannot tolerate, just like if you will see here, now the internet is back. So, I will show you few of the references which I could not show you before. First, I will show you insufflation, that is warming and humidification. Do you know these are the very good warming and humidification insufflation carbon dioxide in laparoscopy. These are 5-year follow up the randomized control trial for the different warming and humidification. So, if you will buy this type of surgical humidification warming CO2, then you are allowed to leak and you are allowed to lose the CO2, there will be no hypothermia, there will be no dryness. But if you cannot do that, then we should avoid it. Now, another that CO2 is the laparoscopy can still be performed in the patient in the ICU. Laparoscopic trauma and ICU or ICU, if you will see that value of laparoscopy in trauma ICU patient, it is there, but only thing is patient hemodynamically should be stable. So, that is why we are talking about the different ASA. So, right now these are the contraindications. So, this is disadvantage, that if it is a more operative time, you cannot do in every patient laparoscopy. Next is potential for major complication in inexperienced hand. Patient came for diagnostic laparoscopy and we have perforated the aorta, is not it, because we do not have any experience of doing laparoscopy. Another is loss of tactile feedback. This is a big drawback of laparoscopy. Our finger is the best instrument God has given to us, because the pulp of the finger has a very dense nerve ending, and just by touching we can diagnose. Suppose patient has mucinous cyst adenoma of the appendix, that gives you rubbery feeling, rubber like feeling of the appendix. But laparoscopy, how can we diagnose it? Our instrument can never feel the rubber. Sometime when you are doing the laparoscopy, sometime what happen, you are doing cholecystectomy and one stone is slipped into the cystic duct to the CBD, and now we are in trouble, because we cannot feel it, the stone we cannot examine, we cannot feel, and that will create the problem. But in open surgery, You can even you can palpate the head of the pancreas. You can examine the entire CVD by the finger. In the robotic surgery, there is one haptic feedback. What is haptic feedback? It is a visual and auditory substitution of the tactile feedback. So, when you do the surgery and suppose you have a little more resistance or you are holding something which is more tight, your robotic console and your master manipulator started vibrating. Just like in the Sony PlayStation 3, which your kid is playing. If one car hit another car, the remote and the console of the joystick started vibrating, and the kids are very happy because they feel like they are really hitting one car to another. This is the meaning of haptic feedback, which is software control. In the robotic surgery, it is available. If you are taking a knot and if you are tightening the knot very tight, you will start getting vibration of your finger. But in laparoscopy, even we do not have haptic, even we do not have finger. So, this is one of the problem. Suppose you are doing colorectal surgery and there is a cancer of the sigmoid. In the open surgery, you can feel the tumor 10 centimeter proximal, 5 centimeter distal of the sigmoid colon, you can resect it out. But in laparoscopy, we never know where is the cancer. That is why before laparoscopy, complete full colonoscopy and tattooing of the tumor is required. So, that during the laparoscopy, you do not have to ask anyone that how much I have to remove, you already know that I have to remove from rectosigmoid junction or I have to go low anterior. So, that you know already. So, this is a drawback. Another is difficult in complicated cases. Laparoscopy can never be guaranteed that you can continue and you can complete this surgery by laparoscopy. Any time it may be complicated. Sometime you have done the entire appendicectomy very nicely, just at the time of removal of the appendix was dropped and it is lost into the coil of intestine. And you are searching it for few hours, you did not get it. And there are a lot of complications. There is a consent you have to take from the patient for everything. If you will put the consent of the laparoscopy and if you will search the patient consent, if you will put the consent and laparoscopy, sorry, it will correct, do not worry. So, and let us write the hospital also. Then you will see this is the patient consent is CE or SE. Yes. So, this is the patient consent in laparoscopy and this is a consent form. It is in your member area also you can download. This is a consent form that interrupted service is required and this is condition and this is general risk of the patient. Like a small area of the lung may collapse, clot may happen, heart attack may happen, death is possible, damage to the large blood vessels can happen, damage to the gut or bladder can happen, rarely gas can go to the heart, breathing problem, television method may fade, deep venous thrombosis can happen, infection of the wound can happen which can create 1 in 20 people, this may need antibiotic, possible bleeding into the wound can happen, weakness can happen, symptom experiencing. So, this is increase in the obese patient for the DVT. This is a consent given by the textbook of Hulka. Hulka is one of the very renowned gynecologists who has invented the Hulka clip for the sterilization, and this is a laparoscopic consent, which is important. You have to sign, your patient has to sign, anesthetist has to sign, and then patient has to declare, relative has to be signed, and then you are safe. But if patient you will explain everything in his own language, then you can understand that many of the patients they will not give you the consent for surgery. They will say that what else is possible, you have written everything including death and all, but it is really possible. So, this is the disadvantage.